Hey everyone, and welcome to this explainer. Today we're diving into one of the most sheerly traumatic injuries the human body can actually sustain, an open tibia fracture. Just picture it, a shattered leg, massive soft tissue damage, and this incredibly complex medical puzzle that trauma surgeons have to solve, usually under immense pressure. We're going to break down some fascinating clinical data and surgical techniques that are completely challenging the traditional playbook for dealing with these devastating injuries.
So here's the core medical mystery we're looking to solve today. How exactly do you fix a completely shattered leg, manage a massive open wound, and set the bone perfectly, all in just one definitive surgery? For decades, the standard answer has basically been, well, you don't. You do it in 3, 4, or maybe even 5 agonizing steps. But the source material we're looking at today, it proves there is a much, much better way.
All right, here's our surgical plan for today's explainer. First, we'll look at the open fracture problem, then the Ilizarov dilemma, followed by this brilliant temporary plate hack, the frame application steps, and finally the clinical outcomes and complications.
Section 1. The open fracture problem. A grueling marathon for the patient.
Okay, so in trauma centers, it's pretty common that patients might not even arrive until days after the injury. And by then, they often have active serous discharge and an infection is already brewing. The bone has literally pierced the skin. Now, the conventional protocol to fix this is, frankly, downright exhausting. First, you have to go in for debridement to clean the wound. Then you apply a temporary external fixator. After that, you're waiting for wound management. And then finally, maybe weeks later, you go back in for the definitive treatment like a reamed or unreamed intramedullary nail. It's an absolute gauntlet for the patient.
Let's just contrast this laundry list of the conventional method against the sheer efficiency of getting it right the first time. Because this multi-step approach isn't just tiring, right? It actively increases the chance of complications. You're risking the spread of infection with every single surgery. Plus, nailing can severely damage the endosteal blood supply inside the bone. But the primary Ilizarov method, it's a single surgery, it completely avoids multiple hardware exchanges, it's elegant. So you're probably wondering, why isn't everyone doing it?
Which brings us to Section 2, the Ilizarov dilemma. Why is the best tool treated as a last resort?
Let's just address the stigma right out of the gate. The Ilizarov frame looks intimidating. Honestly, it looks almost medieval with all its rings, wires, and bolts. And the truth is, young trauma surgeons are often really hesitant to use it. It just lacks that modern, high-tech glamour of robotic joint replacement or slick arthroscopy surgeries. But as you'll see, the hesitation goes a lot deeper than just aesthetics.
The real issue is what we can call the 3D puzzle problem. You see, surgeons love the comfort and control of open reduction. Opening the leg up, seeing the bone directly, and fixing it right there. But traditional Ilizarov application, that relies on percutaneous indirect reduction. You are trying to align a totally shattered bone through the skin using wires. And to make matters worse, at various medical workshops, surgeons are usually taught to apply this frame on a perfectly normal, unbroken bone. So trying to replicate that on a displaced, shattered fracture, it's incredibly difficult.
Section 3, the temporary plate hack, bridging the comfort zone gap.
Now, here is how surgeons are completely hacking the system, and it is brilliant. Step 1, they open the leg and identify the fragments along with their muscle attachments. Step 2, fix those fragments temporarily with K-wires and lag screws. Step 3 is the real game changer. Apply a temporary reduction plate. This acts just like painter's tape. It perfectly aligns the shattered bone, basically turning it back into a normal bone. Step 4, now you can easily apply the Ilizarov frame exactly the way you learned in the workshop. And Step 5, just unscrew and remove that temporary plate. You get the perfect alignment of an open surgery combined with the permanent, dynamic healing of the external frame.
Section 4. Frame application steps. Building the permanent scaffolding.
What's really interesting here is watching this transition. Hands go directly into the surgical site, getting those bone fragments perfectly aligned via open reduction. Then the rings of the Ilizarov are applied right over that now stabilized bone. It literally takes the guesswork completely out of the equation.
Let's demystify the intimidating frame itself for a second, because its design is pure genius. To prevent the leg from bowing inward or outward, that's the coronal plane, the very first wire is placed perfectly parallel to the knee joint. This prevents any varus or valgus angulation. Then, in the sagittal plane, the frame is aligned parallel to the fibula, which stops the bone from bending forward or backward. And as for translation, meaning keeping the bone segments tightly together, surgeons use these things called olive wires. They have a tiny little bead on them that actually pulls the bone right into place.
But here's the thing. The frame isn't just for the bone. It actually acts as a soft tissue traction device too. By using the wires to gradually and gently pull the tissues together over time, surgeons can manage massive open wounds without causing tissue necrosis. It's essentially a bone healer and a skin healer, all wrapped into one.
Section 5. Clinical outcomes and complications. Adjusting the healing process on the fly.
So let's run through the complications. Say there's a malunion, meaning the bone starts healing slightly crooked. Now if you had a titanium rod hammered inside the bone, you'd be stuck, right? Or you'd definitely need another surgery. But with the Ilizarov, the initial malalignment can actually be corrected post-surgery just by adjusting the olive wires and the hinges on the outside of the leg. It's wild. And if there's an infection at a wire site, you don't take the whole rig apart, you just clean or replace that specific wire. Plus, to prevent joint stiffness, strict physiotherapy is implemented while the frame is still on.
And then there's arguably the most awe-inspiring fix of all. What if the trauma caused severe bone loss, resulting in the limb actually being shortened? Well, surgeons can perform what's called a corticotomy. They make a surgical cut into the outer layer of the bone, and then use the Ilizarov frame to slowly, millimeter by millimeter, pull the bone apart. The body naturally fills that gap with new bone. They can literally regrow and lengthen a patient's leg, turning a severe, life-altering complication into a completely solvable issue.
And this brilliantly illustrates the ultimate power of the Ilizarov. It provides continuous correction. It's a living, adjustable healing tool. The gradual compression it provides actually decreases the chance of delayed union when you compare it to nailing. You are actively managing the patient's anatomy while they're awake and healing in the recovery room.
So, the crucial takeaway here boils down to just this one number. 1. By combining the ease of open reduction via a temporary plate with the sheer power of the Ilizarov frame, patients can avoid a terrifying gauntlet of temporary fixators, nails, bone grafts, and endless hospital stays. They require just one definitive surgery.
Now, we might be waiting years for future tech like inert betadine-coated internal plates to fully revolutionize trauma care. But until then, the data in this explainer asks a vital question to the medical community. Why not be aggressive? Why reserve the best tool for a salvage operation? By using this temporary plate hack, trauma surgeons don't even have to be master Ilizarov specialists. They just need the basics to help their patients avoid multiple surgeries. I mean, why not do your absolute best on the very first shot? Thanks so much for joining me on this explainer. I really hope it completely reframed how you look at trauma surgery.